Short question from Laura Adams.
First of all, I've spoken all day. My reputation precedes me.
Sorry about that.
Thank you very much for what I thought was just an incredibly informative panel. My question for you, in looking sort of locally, it's what happened in my own experience, is that these organizations that you represent got really powerful voices when they linked in to the community health information exchange governance structure. For example, our free clinic is outfitted with the same EHR that some of the most profitable, largest physician groups, and we did that because when they got ready to sign their contract, we talked to them and said, could they throw in the free clinic in this? And they said, sure, why not? The free clinic got outfitted. And it's that kind of a thing when you have that central group that feels a deep responsibility for the entire community. I wish Linda Dillman were here because Walmart gave us $25,000 to the Institute to give to Chad Brown Health Center. It meant the difference between a certified and non-certified EHR for them. But we took it on as collective accountability. So rather than a lone voice out there, and one of the messages we heard from the panel prior to us was, don't go it alone. And I guess my question for you is, in our organizations too, the mental health has the person who oversees our entire RIA oversight is from mental health and behavioral health. Their voice gets heard. So what are your organizations doing to encourage your people to step up front and center and get that visibility locally, because it works? When we start hearing about your needs and we have this collective accountability, do you know whether they feel, I saw it was a very small percentage on Michael's slides that were actually involved in an HIE, and I thought, gosh, what a tremendously lost opportunity. So is there work going on to encourage them to get involved?
This is Nicole from the National Association of Free Clinics, and I would say yes. We have, in West Virginia, we had an actual program that was established that encompasses all of the free clinics in West Virginia, and actually most of the federally qualified health centers under Healthy State, one of those programs that we've had in general. We're looking at ways where we've explained to them that a collective and united voice obviously is one that works better than everyone doing it out for yourself. So I think that what we're also finding, however, is there is, and we've talked about this before, there's a great deal of confusion out there in the world between what a free clinic is and what a federally qualified health center is and what anything else could be. So one of the problems that we get is, well, when we get to the table, they say, well, we thought you already were funded. And we have to say, well, no, we're not, because we're not a 330. And we have found that and we have all the material we'll be happy to share, by showing you some of the documents that we give to people and the meetings and telling them when meetings are and who to get the meetings with. But we're very active. I mean, 17,000 letters were sent to the House and the Senate just to get us under the essential providers section in the Senate. And then on the local level, what we've done is they have state associations. Many of our free clinics have a state association, just like a primary care association, but they have an actual free clinic state association that goes forward and helps them get these type of opportunities to go to someone who's looking at an EHR across the board and say, we have 3 free clinics. Can we be a part of that too? Because, and we're finding that it works like that as well in some states. And in other states, not so much. To quite frankly, there is not an easy solution when you look at a California compared to a North Carolina, or that's where we're finding states that we're going to have 2 very powerful state associations doing almost the same thing, but it's hearing deaf ears in one and some not so much on the other. So we're learning, I think, also that a cookie-cutter approach to talking to people isn't always the way to get your voice heard as well.
This is Ruth Perot. I wanted to add that in the state of Maryland, our organization was part of a planning effort to ensure that the voices of the community, the full spectrum of voices, were heard in an effort that is just recently being funded at the level of $10 million to establish an HIE across the state in various counties. So we're making, as advocates, we're saying you have to have these voices at the table. Everyone has to be involved. If otherwise, it's not a real HIE.
And put a strong and unrelenting voice there.
All right, thank you. That would conclude this portion of the presentation. I'd like to thank Ruth, Nicole, Yvonne, and Alexa for your presentations, and also for the questions from outside. There were a couple other questions that came in we can't get to now, but we will try to follow up with you folks through email to answer your questions as well. And appreciate the questions from the board also.
And Michael, before we finish this, I just wanted to thank you. I think this has been extremely helpful, I think, for all of us. So
very good. I'm glad we're able to do it.
Before you leave, though, I too thought this was really exceptional, and I think that it is a very important part of what NEHC does, is to bring the stakeholder communities here to listen to you from your view on the ground. One of the things that strikes me, though, and I am from Philadelphia, is that the perception, I think, is that they're relatively independent, freestanding entities that are providing care for the underserved in the same community. And I think one thing that we need to think about how best to do is, what is the organizing framework for a community to provide health care? And there are two important points. One is, there are multiple, but there are a couple. One is that, as Ed Wagner has thought about the chronic care model, it's always portrayed as receiving care within the community in which patients live. And what I don't see is the community as a whole taking ownership and certainly working on getting funding from other places, but taking ownership for the coordination of care within the community in which patients live. And at times it can be almost perceived that they're entities competing with each other for funding or resources to do certain things. And I would doubt that most of the communities has a clue what's going on with all of these entities. It certainly comes to pass as if you're a patient. There are members of my family that volunteer in free clinics, but they don't necessarily see that free clinic is a resource within the community at large. And I doubt that the City Council spends a lot of time thinking about how are we going to coordinate this care. The second point is around all of this talk about healthcare reform right now, and of course the Congress, sometimes at their peril, coming to communities to talk about what might or might not be in the federal legislation, and having individual citizens say they're listening, sometimes not listening, but participating in this debate. But what strikes me is you don't see, at least I haven't seen, any evidence of the communities in which these patients living also participating in this conversation. Either the town, the region, the state, it's the federal government and the citizen, and nothing in between. And ultimately, I think we have to figure out how to organize care where people live. And if you really are going to be true to the principles of patient-centered care, it has to be seen from the lens that they look through in their community now. So that's not a question, and obviously is a comment, but I try to take away really solid lessons that you provided for us today, and to help us in our thinking as we work with the Office of the National Coordinator now. So thank you so much. And if you have time, we'd love to have you stay for lunch with us, and just so we can bend your ear a little bit more. Now, all right, I'm going to close this portion of the public meeting, and we will then move into the public comment portion of our agenda. I just want to remind everybody that during the executive session we'll be holding after lunch, that the board is going to continue to focus on its strategic planning, as well as to review the findings from our Finance Committee about our most recent audit. I'm about to open the floor for comments from the public and anybody here in the room. And if you have joined us in person today and would like to make a comment, please come to the microphone. If you're participating electronically and would like to make a comment, you must be logged into the webinar and have used a webinar-generated attendee ID when you dialed in over the phone. This combination is the only way that we can identify you so that your phone line can be unmuted individually. And believe me, I'm reading from a script since I know nothing about this personally. To let us know that you would like to be called on to make a comment, please signal your interest in speaking by clicking on the raise hand button that appears as a picture of a hand on the webinar just on the list of today's participants. Or if you would rather, please feel free to send us a comment online and we'll read it aloud at the end of the comment period. And given the time availability, we'd ask that you keep your comments to 2 minutes, please. Are there any comments? Okay. Seeing no comments, we will adjourn the public portion of our meeting. And thank you, the members of the audience who were here with us today in person, and very much for those who participated through the webinar or on the phone. Thank you so much, and we'll consider this portion of the meeting adjourned.